First of all, thank you for, you know, uh, promoting me, Marty. The fact is there are many, 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 many good people doing cognitive behavior therapy all over the world, and I'm sincerely honored to be part of that group. And what got me interested in shifting from full-time academics into clinical work was one of my good friends at Yale, Dave Balla, who was in the psychiatry department, I mean, the psychology department at Yale, working with Ed Ziegler, uh, committed suicide, died from suicide. This is back in around December, early January 1982. And I was just devastated. I was surprised, as anybody who has had a friend or family member who's died by suicide. And I had been reading some of the work by Aaron Beck on cognitive therapy of depression. So I then decided I would shift out of academics into, full-time clinical training. And I went to University of Pennsylvania Medical School and did a postdoc with Beck. Um, and to this day, uh, I feel, I mean, like a lot of our classmates who have retired, I feel like a colleague of mine who does research on depression, our work is not done. We still have people who are depressed, people dying by suicide, people who are anxious, people who are troubled. So if we save one life, it's worth it. It's really worth it. And my brother once asked me, he said, "Don't you get depressed talking with depressed people?" And I thought, I actually don't. I actually feel that if I can help them, I can't think of anything better for me to do. If you have questions, put them in the chat feature, which should be on the bottom of your screen.
And send them to Barry Bardo.
Okay, you see the screen, is that right, Marty?
I do.
Okay. All right, so what do we mean by depression? So in psychology and psychiatry, we have a diagnostic manual, which in a way is a fictional guide to psychiatric problems because there are probably 1,100 ways in which somebody can qualify for the diagnosis of major depression. But what it is depressed mood, loss of interest or pleasure, so the lack of pleasure in activities, significant weight loss or weight gain, where the person's not trying to lose weight, insomnia or hypersomnia, increased need for sleep, psychomotor agitation, where they're really agitated, or retardation, they're really slow down, fatigue or loss of energy, feelings of worthlessness or guilt, or a lot of self-criticism, self-loathing, inability to concentrate or indecisiveness, recurrent thoughts of death or suicide. And these symptoms must be present nearly every day for 2 weeks and must cause some impairment in functioning. Probably everybody has some of these symptoms at some point, but you would not qualify for the diagnosis of major depression. You might have an adjustment disorder or something like that, but major depression is very serious. Um, a lot of this is taken from the book that I'm finishing on uh, treatment plans and interventions for depression and anxiety, the third edition. Um, so bear with me with some of the hairy details. So lifetime prevalence is 16%. Um, Now it varies for males and females, and pretty much in all cultures that have been studied, females are more likely to be depressed than males are. Um, the 12-month and lifetime prevalence, 12-month is 13.4%. So during a 12-month period, about 13% of people are depressed, but lifetime about 26% um, among women and 14% among men. So you can see that lifetime, a significant percentage of the population qualify for major depression. These are very large studies where people were interviewed, um, and it's also something you find in other countries. One thing that's important to keep in mind is that for a significant proportion of people who have an episode of major depression, a significant proportion of them will have other episodes. So we want to be aware that uh, that depression is for many people a lifetime chronic diathesis or vulnerability. So, for example, um, if you've had 2 episodes of depression lifetime, you could be expected to have 7 episodes of depression, which is important because some people may come in and just have one depressive episode, like a divorce or loss of a job, and never be depressed again. But then there's some people who have recurrent depression. And what you want to do is you want to be able, with those people who are prone to recurrent depression, to have some um, inoculation against future depression or some maintenance treatment, either with ongoing cognitive behavior therapy or mindfulness training or medication to reduce the likelihood of future episodes. Um, and what we know for future episodes is that there's some evidence that future episodes are less likely to be triggered by life events and seem to have a life of their own. It's called the kindling effect that, if you have several episodes, you can just have another episode because you're just predisposed to having depression. And what's interesting is that the rates of depression vary significantly for different age groups. And the highest is people between 18 and 29, uh, followed by people 45 to 64 and 65 and over. Um, and what we're finding is in today's cohort, so to speak, in today's testing of young people, we're finding higher levels of depression than we did 30 or 40 years ago. It used to be that people who were younger had lower rates of depression. Now they have higher rates of depression. And there are a lot of theories about why that might be the case, uh, which uh, colleagues like Jonathan Haidt at NYU and others have looked at. Haidt's book, The Anxious Generation, which came out this past year. Jonathan Haidt is a Yale College graduate. Um, there are coexisting conditions with depression, such as hypertension, diabetes, and other disorders. Um, People who have alcohol dependent alcohol use disorder, very, very high rates of depression, about 64%. So as people will say in AA that there's no problem that alcohol won't make worse. Um, and it's also, when I say the diagnostic manual that somebody comes in with depression or they come in with post-traumatic stress disorder, the reality in everyday practice is people qualify for multiple diagnoses. So a person can qualify for major depressive disorder and panic disorder and generalized anxiety disorder. And people with post-traumatic stress disorder, that 90% of them qualify for another disorder. And substance abuse, as I say, is also coexists with depression and anxiety. A tremendous overlap between depression and anxiety. 85% of people with depression have significant anxiety, and 90% of people with anxiety have depression. So in some ways, there's a lot of overlap between depression and anxiety. So there may be a common vulnerability. Um, it's one of the leading causes of impairment for people between 15 and 44. It's a leading cause of disability. So, people, 322 million people worldwide have depression. Um, it results in 2.7 million disability adjusted life years. Um, so it's a devastating disorder. And even if you stay alive with depression, even if you go to work, it's so difficult to be depressed. And I think that having compassion and allocating the resources for the treatment of depression is important. People are impaired with depression. 80% of people with depression are impaired in their daily functioning, and they lose an average of 5.6 hours of work per week. And half of it is loss due to absenteeism, short-term disability. So one thing to keep in mind about this is that because of the economic and the loss of work um, in the United Kingdom, uh, uh, David Clark from Oxford and Richard Laird, who's a labor economist from London School of Economics, helped convince the Tony Blair government to institute a, countrywide uh, treatment program called the Initiative for Accessible Psychological Treatments, where they would provide through the National Health Service basically cognitive behavior therapy and a short-term modality. Because what they found from a compassionate point of view, obviously, you want to provide treatment for people who are depressed, but also I think this is on a automatic uh, transition. People with depression are not going to work, they're not paying their taxes, and they're overusing other medical services. So this program has been in existence now for about 15 or more years. And like in any 1 year, 1.8 million people get treatment for depression in the United Kingdom. And it's reduced the utilization of other medical services. Um, so it's something that we want to keep in mind as a economic risk, and that it actually is worth it to invest in treatment. Depression, there are different ranges of heritability for depression between 37% and 66%. Um, so there's no one figure that everybody agrees on, but there's a significant heritability, but there's a lot of other factors that may account for depression. Um, Life events, socialization, uh, cohort effects, like people today are more likely to be depressed than people 50 years ago. So the suicide rates are also very high. Um, that people often get news about homicide rates, but depression, that suicide rates are twice as high as homicide rates. As I said, two of my very good friends died from suicide. Uh, Females are much more likely to attempt suicide, but their attempts are usually overdose or cutting, which are not as lethal, and males are more likely to hang themselves or shoot themselves. And males are four times more likely to die by suicide. And suicide rates increased between 1999 and 2017 by 33%. So this is a major medical quality of life issue. It's higher for people whose parents have divorced or separated or died, people who have been sexually abused or any abuse, much higher rate of increased depression. So these are early childhood adverse effects. As a psychologist or psychiatrist, you often will think, well, why did my patient die by suicide? I have to acknowledge I'm fortunate. I've never had a patient in treatment who's died by suicide. I've had patients attempt suicide. I've been lucky, but my colleagues, almost every one of them has had somebody die by suicide. So why does a patient die by suicide? Well, part of it is genetics, could be biochemical disorder, past attempts, which makes them more likely. There's kind of a momentum effect toward more suicide, recent events, impulsivity, not using the tools, factors that are unknown, hopelessness, drug, alcohol abuse, access to means. One of the biggest predictors of suicide or access to a gun. And for example, Montana has one of the highest rates of suicide. It's a gun culture. Um, so you want to think about when people die by suicide. Um, you don't know what you don't know. You can't control what you don't control. You only see a patient maybe for 45 minutes a week. I'm not saying you have no role in it, but there are many, many factors that affect suicide. Um, This is Aaron Beck, Yale Medical School graduate, Brown University College, uh, one of the most influential psychiatrists in the history of psychiatry, uh, developed a cognitive model. We call him Tim, Aaron Temkin Beck. And Beck was a doctrinaire psychoanalyst back in the 50s and 60s, and he thought, I'm going to test out the psychoanalytic theory that depression is repressed hostility. So he began collecting data on the dreams of depressed patients, anticipating that their dreams would be filled with a lot of anger and hostility. And much to his surprise, the dreams were filled with depressive content of loss, rejection, despair, that kind of thing. And so he began thinking, well, maybe I could look at the conscious thoughts of depressed people, their thoughts about their negative view of themselves. I'm a loser, experience, nothing is pleasurable, the future is hopeless, what he called the negative triad. And so initially he thought that cognitive therapy would be an extension of what was called ego psychology and psychoanalysis, like people like Heinz Hartman and other people, Roy Schaefer and others. Um, but the psychoanalytic community rejected him. So he went off on his own with that. Um, so he argued that we have to look at the relationship between our conscious thoughts, our emotions, and our behavior. And that's what we do in cognitive therapy. Um, so what are automatic thoughts? Automatic thoughts, let's say I have an automatic thought, I'm a loser, or everybody listening to this thinks I'm an idiot. They occur spontaneously. They just occur spontaneously. They seem reasonable to me, right? Maybe I am a loser. Maybe I don't know what I'm talking about. And there's a bias or a predisposition toward the negative. And so Beck decided, let me see if I can categorize the various ways in which depressive thinking seems to manifest itself. And he called these initially cognitive distortions, and you can think of them as unhelpful ways of thinking. So one way of thinking about it is that, let's say we have fortune telling, like my mind is going to go blank and I'll look like a fool. So, or I'll always be alone. Um, so somebody who's depressed might go through a breakup or they're feeling lonely and then they think I'll always be alone. Or labeling, you define yourself entirely by one rigid negative description. I am a failure. So if I fail at this, I am a failure. Or overgeneralizing, taking one example and generalizing this. If I fail at this, I'm going to fail at everything. Um, or discounting my positive, claiming that a positive doesn't matter. I had a patient um, who had a hedge fund and he lost tens of millions of dollars. He had several hundred million of his own money still intact. And he thought, my God, I'm a failure. I should check him to a hospital. Discounting his positive, all the money, success that he had, and all the philanthropy that he was doing. Um, Anybody could have done that. That's trivial. So we want to look at the way the person is consciously thinking or catastrophizing. That an event that happens is absolutely terribly bad. If I get rejected or I don't do well, it's awful. We broke up, the end of the world, as opposed to it's a temporary inconvenience or a difficult time for right now. Or mind reading, people think I'm boring and stupid. Or emotional reasoning, because I'm feeling sad, things won't work out. It's kind of reasoning from my emotions, kind of a circular type of process. Or unfair comparisons, comparing myself with somebody who extremely successful, or constantly focusing on judgment. I should have done much better than I did. Or personalizing, taking things personally, like, somebody holds a party and somebody's not having a good time. It must be my fault. Or you're working on a project, uh, the project doesn't work out. It's because I failed. It's not due to the fact that there were a lot of other factors involved. So what we do is we sort of start with kind of identifying a core belief that a person has about themselves. So let's say the core belief is I'm a loser. All right. So the person is like looking at the world through a lens. I'm a loser. Not that they want to think they're a loser, but that's just a bias that they have. And then they may have a set of unhelpful or maladaptive assumptions. For one, could be I need everyone's approval. Um, and that then leads to these automatic thoughts. I mind read, he thinks I'm a loser, or personalizing, it didn't work out because I'm a loser, or catastrophizing, this is going to be terrible because I'm a loser, or emotional reasoning. I feel bad, therefore I'm a loser. And so it becomes a kind of vicious cycle of feeding into the core belief. It's almost like this process of circular um, belief is like it's like it conserves the negative belief. It's a conservative self-maintaining system. It's kind of like your Google algorithm that keeps you in your little silo. Um, so let's say you have a negative event, somebody goes through a breakup, and that activates their personal belief, or what we call a schema. Schema is a belief. I'm a loser. And then it activates automatic thoughts. I'll always be alone. Um, it's all my fault. And maladaptive assumptions. I can't be happy unless I have a partner. Uh, I must make everything work out. And then probably problematic ways of coping, like over drinking or using drugs or isolating myself or ruminating. And so this kind of vicious cycle is each point of which we want to intervene. We want to start with problematic coping like drinking and isolation and or rumination and look at their beliefs and their assumptions to see if we can help them change the way they believe, the way they think about things, and the way they cope. So we're actively engaged in examining and testing out, giving patients homework assignments or self-help assignments, and then measuring their symptoms week to week to see if they change. So let's say you're rejected by your partner and that activates your belief you're inadequate and unlovable. I mean, it could activate the belief that your partner wasn't a good fit for you, but for the depressed person, it activates the idea that I'm unlovable. And I personalize it and catastrophize. I'll never be happy. I'll be miserable all my life. And if one person doesn't want me, it means I'm a loser. No one's going to want me. And then I begin activating rumination and avoidance, and that just keeps the depressive cycle going. So we want to break through with that cycle, and we have a lot of techniques that we can use. So one of the symptoms in depression is hopelessness, which is one of the main things that we want to get to early on. Hopelessness is a feeling of being trapped, no way out of my suffering. It's a major cause of suicide, and it's a major consequence and cause of depression. It keeps you in that cycle of hopelessness. Um, so how do we go after the hopelessness? We don't take a passive role here. So first, we normalize that hopelessness is part of depression, and there's a short-term psychodynamic model called interpersonal psychodynamic therapy that normalizes and medicalizes depression. It's kind of a medical illness, and these are all part of your depression. And I actually use that model that this is part of your problem. This is how depression functions. That depression has a mind of its own. Um, Second, you can't be hopeless about the present moment. And so a lot of times we want to teach patients mindfulness, focusing on the present moment, focusing on what they can do. Also look at the advantage of hopelessness. So some people with chronic hopelessness also have a fear of getting their hopes up because they don't want to be disappointed. Although I don't think that's what drives most people who are hopeless. What are the reasons for thinking I'm hopeless? So some could be I'm feeling hopeless, or this relationship didn't work out, so they overgeneralize. Um, what would have to change so you're not hopeless? Get a new partner, something going better at work. Examining is your hopelessness a self-fulfilling prophecy? So if I'm feeling hopeless, do I then avoid and isolate myself and become inactive? And that just adds to my hopelessness. So one way of thinking about it is act against my hopelessness belief. Act as if I'm not depressed. So begin doubting your hopelessness. Some people say, well, I believe I'm hopelessness. And I say, you can hold on to that belief, but I want you to just open your mind that maybe there's a possibility that your belief might be too extreme. To act against your hopelessness. What would you do if you were not hopeless? think about what is not hopeless. So, for example, I remember years ago going through a breakup with a girlfriend years before I met my wife. I was feeling hopeless. Then I thought, gee, what's not hopeless? I can see my friends. I can, get my work done. I can go out with other women, that kind of thing. Um, to think that no one person or experience is necessary to your happiness. I don't mean to minimize the importance of a partner, but you had a life before the partner, and you have a life independent of that person. So we want to look at the belief that certain things are absolutely essential, and I can't function without it. Um, uh, have you felt hopeless before? Did things change? Which is interesting because hopelessness is often a temporary belief. If it's a temporary belief, then it's by definition contradicts itself. I'm hopeless for now. Well, what does that mean? That means it's not hopeless forever. Um, what obstacles have you overcome before? So, have you overcome depression before, or loss of relationship, or loss of a job? Are there techniques and medications that you have not tried? So, a number of years ago, I decided to write a book on cognitive therapy techniques because I found that a lot of therapists use maybe 5 or 6 techniques. So I wrote a very long book called Cognitive Therapy Techniques, where I had 110 techniques with extensive examples of them. So if these first 5 techniques don't work, we have another 90, we have another 105 techniques. We have medications. Uh, we have electrical treatments, transcranial magnetic stimulation. We have ECT. We have ketamine. We have all kinds of combinations of medications. There's no end to what we can use. Um, we also think about self-criticism as a symptom of depression, which is marked by regret, feelings of guilt, tendency to ruminate, inability to take credit of your positives, helplessness and hopelessness. Um, and cognitive therapy and some other forms of therapy like compassion focused therapy and acceptance and commitment therapy can be very, very useful with self criticism. But I'll give you some examples of some things we can do. Um, we can begin looking at some of the ways in which we respond to our self criticism. So people who begin ruminating repetitive negative thoughts over and over about how I mess things up. And I'll get to that a little bit later about what we can do with rumination. We can look at who you compare yourself to. So a lot of my patients are highly ambitious and they compare themselves with people who are exceptionally successful. Um, your idea you can't enjoy any activities because it reminds you uh, uh, about how poorly I'm doing. So I can't enjoy because I remember when I was doing better when I was doing these activities. Uh, Self-criticism also adds to your indecisiveness because you think I can't make decisions. I have no confidence in myself. So self-criticism is a central feature. Um, so what you want to do is we want to identify the negative thoughts. So let's say the negative thought is I'm a failure. Define my terms. What do I mean by failure? Somebody who never succeeds at anything. What is the evidence for and against your criticism? So think about all of us here in our talk today. What is the evidence that you're a failure? Maybe you didn't have as much success as somebody else. Um, what is the evidence that you've had some success? Maybe you've had a family, you have a partner, you've done some good things, you've done some good things with your work, you had a Yale education, you made professional school, all the things that you would give credit to another person for. Is there any advantage of criticizing yourself? Which is interesting. This is part of the resistance that some people think I need to criticize myself to motivate myself. I don't think I've met anybody who says I attribute my success and satisfaction in my life to my self-loathing. You know, uh, uh, I'm driven personally by curiosity. I'm just curious. I have this mind wandering. I'm just fascinating with a lot of things. I'm not getting ahead with self-criticism. And we can think about self-criticism with self-reward. Give yourself reward for everything you do. I remember talking with a patient who was self-critical, and I told her, she thought that being self-critical would be to get herself motivated to do things. And I said, well, how's that working? It's making you more isolated and um, encumbered with your negativity. And I said, if you were trying to teach your dog to do more positive things, what you do, and she would say I would reward it. And I said, why don't you treat yourself like you're a dog? And she said, are you telling me I should be my own dog? And I said, yes. Uh, um, Another thing is, do you really need to evaluate yourself? Why don't you just accept yourself and give yourself credit, or just simply enjoy and be challenged and be curious? Um, you can replace evaluation with observing and accepting. So rather than evaluate your performance, you can just simply say, well, I gave this talk and this is what I covered, this is what I did not cover, and I accept it. Um, so there are a lot of techniques that we can use, and I know I'm going through these rapidly. Just wanted to give you a failure. I think another thing is don't take yourself too personally. We always think we're the center of the universe. Um, or think about self-correction. Like there's a concept in social psychology that Carol Dweck at Stanford developed called the growth mindset that many of you have heard of, which is to feel challenged, to think about how I can grow and how I can learn from my mistakes. Um, Use the double standard technique, like would I be so critical of another person? Would I be critical of my friend or my son or my daughter? Um, do I have a rule book that I have to be so completely perfect in order to accept myself, humanize my mistakes, that like all of us, I'm a fallen angel and we all screw up on times. Um, and also to think about your maladaptive rule book. So many of our friends and our colleagues and ourselves will have this kind of very demanding standards about the rules we have to follow to accept ourselves. So I should be successful at everything I try. If I'm not successful, then I'm a failure. If I'm failure, then I'm worthless. Failure is intolerable and unacceptable. I should get the approval of everyone. So you kind of get the picture that these are very self-punitive assumptions. Um, if I'm not certain, then the outcome is negative, right? So equating uncertainty with a negative outcome. I should never be anxious, depressed, selfish, confused, uncertain, unhappy with my partner. These demanding and incredibly unrealistic rules just make you much more vulnerable to depression. Um, you could think of going back and modifying it. Everybody fails at something. Um, Successful people fail at a lot of things. Uh, Apple Computer, they've had a lot of failures. Warren Buffett and George Soros have made a lot of mistakes. If I fail, it means you're a human being. Um, Failure is part of being a player, being involved. Um, I should get the approval of everyone. I remember when I was in college, there was one guy in my college who I thought didn't like me. And I thought, gee, I can't understand why this guy doesn't like me. I was so narcissistic. I thought everybody should like me. And a friend of mine on the faculty, Danny Daniels in philosophy, some of you might have remembered, um, I was talking with Danny. He said, you know what I've learned is that no matter what you do, there are some people who don't like you. And that was such a relief to me. So, um, but anyway, you can get the picture of the kind of assumptions that we can have that will make us so vulnerable to being depressed or anxious or angry. Um, that changing these assumptions can go a long way. And by part of it is thinking about what assumptions would you have about other people. So, like, let's say, for example, somebody who discounts your positive, anybody can do that. Um, but if you don't give yourself credit for positives, you only have the negatives left over. Uh, Wouldn't you give somebody else credit for this? So some people think, well, I don't want to give myself, that's pathetic. No, it's actually the way you would treat your children or your partner or your best friend or even a stranger. I can't do anything right. Think about that, all or nothing thinking. That you do nothing wrong, nothing right. Make a list of some of the things you've done right and make a list of some of the things you've done wrong. And then actually go about and ask other people, what mistakes have they made? A lot of my writing has to do with mistakes I've made. Uh, I wasn't validating patients. I was jumping down their throats with techniques, and I was sticking with one model, and I wasn't as flexible. Um, I wasn't doing it. I wasn't really meeting the person where they were, um, or I was defending the brand. Um, so having a kind of adaptive humility about growing with your work and growing with your life, making mistakes part of the journey. Um, I remember uh, when I used to do a lot of windsurfing, I would try to sail as close to the wind as possible before falling so I can get better at windsurfing, which meant I fell in the water. Only a loser does as bad as I did, but if all of us make mistakes, um, it can't be that all of us are losers. I'm always screwing up, which goes far beyond the truth. What would your best friend say to you on your behalf? Um, so some of my good friends are on this meeting, and I want to shout out to you how much I love you and value your support over the years. You mean a lot to me, and I want uh, to spend the rest of my life having you as my friends. Um, or about one of the things with depression is building your motivation to change. I can't get myself to do anything. And so this is the behavioral activation model of depression, which is that depression is due to isolation. When people are depressed, they isolate themselves, they become passive, they become self-preoccupied, they ruminate, and that just leads to withdrawing from rewarding activities. So if I'm depressed and I just sit in my apartment, ruminating and isolating myself and spending 14 hours a day in bed, I'm not interacting, I'm not learning new things, I'm not connecting. It's a very key thing to get yourself active and to set goals. I'll tell you about my story that, so some of you know, I grew up in New Haven. My parents were divorced when I was a year and a half. My mother moved us from Alexandria, Virginia, back to New Haven to live with my Italian grandparents. And then we moved into a housing project in New Haven, which was 90% Irish. Uh, and and I thought, I wanted to go to college, and the only college I knew about was Yale because I was in New Haven. So I wanted to get out of this poverty. I wanted to go to college. So at that time, I didn't realize I was actually doing cognitive behavior therapy. I would actually keep track of my learning and my reading and my vocabulary every day, monitor my reading. I wanted to uh, be the head of everything, the head of the debating team, the head of the current affairs club, the editor of the newspaper, uh, because I knew it was going to help me get into college. Um, I mean, I would play basketball and sports with my friends. I had a girlfriend, but I realized I had to set aside time I had my goals. I had my goals in front of me. I was willing to delay gratification, to put things off. And my mother said to me when I was in uh, senior in high school, don't expect to go to college. We can't afford to send you. I said, I'm going to go to college and I'm going to get uh, a uh, um, a scholarship to Yale. I mean, what talk about narcissism? I mean, you know, I'm very lucky I got in. But um, so you have to. One of the things you can do with people who are depressed, you can give them behavioral assignments, but they don't always do them. Like I don't really want to do it. But think about all the things you do every day you don't want to do. like, going to work or exercising, taking care of your family or whatever. I shouldn't have to do things I don't want to do. You're not a child. You do things that you don't want to do so you can get what you want to get. Um, Interesting thing, people who are depressed predict that if they do this activity, it'll be really unpleasant. So we have them predict their pleasure in mastery and then carry out the activity later and see, was it as unpleasant? Was there any pleasure they got? Was there any sense of competence? Um, so we take their thoughts and we basically do an empirical test of them. And a lot of times people are surprised. Yeah, really enjoyed that. That was actually meaningful to me. Um, or people, I'm not ready to do it. I'm completely against the readiness model. I'm always thinking you have to do things you're not ready to do. It's a difference between feeling I'm ready versus being willing to do the hard things. So I have people, I have a concept I call constructive discomfort and successful imperfection, to do something every day that's uncomfortable to make progress. Um, so we can think about building motivation by relying on habits, not on feelings. So if your habit is to work out every day, like my friend Dave, who gets up early in the morning and does mindfulness and does Stairmaster and all that, um, committing to the habit, not to your feelings, identifying your goals, asking yourself, what kind of person do you want to be? Do you want to be a good parent? Do you want to be a good friend? Do you want to be a good member of the community? What did you do when you were not depressed? So that's the act as if. When you're not depressed, you're interacting with people. Try it out. Try it out for a month. Act as if you're not depressed. Set specific goals every day. Plan and predict your pleasure and effectiveness. And make this choice your choice. I'm choosing to do these activities even though I don't want to do it, even if I doubt it's going to work. And then have a menu of pleasurable activities or meaningful activities and sample them. So it's a very activating type of model. It's kind of like the Nike commercial, just do it. Um, you can look at your excuses and act against your thought. Um, the other thing is that motivation sometimes comes after the action. It comes action, and that if you exercise, sometimes you actually feel more motivated, you feel more energized. The other thing is don't expect an immediate payoff. So let's say you're out of shape and you go to the gym and you think, gee, I'm still out of shape after 45 minutes. Take an investment model. Go to the gym and work out for several months and see if you make any progress. That's progress, not perfection. Rumination. Rumination is this repetitive negative thoughts of I'm a loser, I can't believe that happened, why is this happening, it's so unfair. Um, this excessive self-focus. And there's actually one approach developed by a psychologist Ed Watkins at the University of Exeter in UK, rumination-based cognitive therapy, where he just completely focuses on rumination. Um, so you start with the assumption like everything should make sense, the life should be fair, I need to understand. If I ruminate, I'll figure it out. I have to have clarity, it has to make sense. Um, and these repetitive negative thoughts about the past and present lead to bad feelings, which then leads to withdrawal, inactivity, negative focus. So I I remember many years ago when I was first learning cognitive therapy, uh, I was ruminating about a breakup with a relationship, and I was ruminating and ruminating and ruminating. And then I realized even if I got the answer why she broke up with me, I still didn't have a girlfriend. So why don't I use, rather than why, I thought, how can I get a girlfriend? So I thought, well, maybe I can figure that out and get a girlfriend, which I was able to do, which I know is surprising to everybody who knows me. Um, so thinking about how to overcome rumination, You can think about the cost and benefit. Do you really think that rumination is going to help you? Has it solved your problem? We can also set a time, we can set time aside for rumination time. So rumination delay. So at 3 o'clock in the afternoon, I'm going to spend 20 minutes ruminating and then ask myself, is this really helping me? Or thinking about how can I make my life better? What are some activities I can engage in rather than rumination? I can shift attention. Um, the answer, the answer to why these things happen or why am I upset or why is it unfair does not give you the answer to how I get better. How I get better involves accepting you have an intrusive thought, but then acting in the real world. So accepting that I have this background noise, my rumination, but then I'm taking action in the real world. So we use some metaphors to think about rumination. So you think about these are four metaphors. My intrusive thoughts are trains in the station, clouds in the sky, thought balloon, telemarketing call. Let me explain. So trains in the station, these are the trains coming in and out of Grand Central Terminal, and each one is a rumination train. Do I want to get on it, or do I want to take a different train, which is getting me into action and how I can make my life better? How can I get in touch with my friends and spend more time and be more mindful and more active? Don't get on the rumination train. So trains in the station is a metaphor developed by Adrian Wells at University of Manchester. A lot of research on that model that is called metacognitive therapy. Um, or clouds in the sky. You can think about an intrusive thought using a mindfulness metaphor. These intrusive thoughts are my thoughts as clouds that pass and go. And you can get spaced out just looking at the clouds as they pass and go. Or think about thought balloon. A lot of my creative patients like that. I'm holding onto the balloon and that's my rumination. But what if I let that balloon go and watch it drift away? You get that feeling of lifting spirits. I let it go. Or thinking about the rumination as a telemarketing call. All of you have phones that tell spam, likely spam, or telemarketing, or unknown number. You can hear the number, but you don't have to pick it up. You don't have to engage in it. Or you can pick it up and then hang it up. That's a telemarketing call. You don't engage. We could think about regret and guilt as some other aspects of depression. And we could think about how we can what did you actually do? So let's say somebody goes through a breakup. They think about the mistakes that they made. What was the actual harm? Both people were unhappy. But maybe you were exercising your rights. You were being assertive, or you were just being human. What did you actually know at the time? Did you actually know that this was going to be upsetting? Did you actually know that your partner might use that as a reason to break up? What were your intentions? Were you provoked? Were there other factors that limited your freedom? Um, Thinking about uh, all like somebody going through a breakup, let's say in a relationship, were there other factors that were involved? Is your guilt proportional to what happened? Is there a statute of limitations on your guilt? Now, you could have people who made mistakes 10, 20, 30 years ago, but at some point, maybe there's a statute of limitations. And rather than focus on your guilt, you can focus on becoming a better person. You always have control over becoming a better person. You can always go out and do something to be supportive and kind to somebody else. And finally, you can think of guilt as unfinished forgiveness, that maybe it's time for you to show some compassion toward yourself, you know, to actually think about, I'm remembering when my friend Paul Gilbert in England was describing um, his model compassion focused therapy. And the exercise would think about somebody who you associate with love and kindness and warmth. And I thought about my Italian grandmother, my Nani, and she was just so filled with love and warmth. And I remember she said to me when I was a senior, I said, Nani, I don't know if I want to be a psychologist or a lawyer. And she pinches my cheek and she says, Roberto, I know you're not going to be a lawyer. You have a too kind of heart. Um, so thinking about directing compassion and loving kindness toward yourself, or even directing it towards somebody else, which can activate that. And think about the voice of compassion and love that you might have heard from somebody in your life. It could be a friend or your mother or your father. And finally, like in anything in life, you can either fix the blame or you can fix the problem. But you don't need to do both. If you were to blame for something, try to fix it or try to make yourself a better person or try to help somebody else. But fixing the blame, making yourself the problem, and then blaming yourself and ruminating and making yourself depressed is not the humane thing to do. It's not a fair thing to do. It basically is something that is unkind to you